it's my great pleasure to introduce Dr. Andre Kushniruk, who is a professor in the School of Health Information Science at the University of Victoria. And Andre, are you still the director, or did you step down, or what?
No, I've got one more year left.
One more year to go. Okay, and then it'll be sabbatical time, I guess, and
Yeah.
but a little easier time. And so Andre is one of the leaders in the world in bringing cognitive science to biomedical informatics. He started off with a Bachelor of Science in psychology and biology at Brock University, and then he went to McGill University, and I think that changed his life, fair to say, because he got a master's in computer science there, and then met Vimla Patel, who also one of the leaders in cognitive science, was on faculty there, and he got his PhD then in cognitive psychology. And that's where I met him, because I was starting to work with Vimla on a number of projects, and we published quite a bit together. You were at Columbia briefly. Were you a research scientist?
No. Yeah, I actually never lived in New York. I just was there so many times. Everyone thought I lived there.
Okay, I thought you were there for a bit, but then you were at University of Toronto, University. York University, and then 20 years ago landed at University of Victoria, where you're at now. Inducted into ACME in 2009, and his work is on, as I guess we're going to see, evaluation of effects of technology, human-computer interaction, and human factors in healthcare informatics. And he pioneered some novel methods for conducting video analysis of computer users. And the work he did with me, I have to just take a minute to say, because we did some really fun stuff. One of the things we were doing back in I guess it was the mid-90s, was we were looking at giving patients access to their own record via the web. And so the question was, what are they doing with this? Because now they're working at home, we can't observe them, we can ask them, we can do surveys, but we were able to do video analysis using remote video capture software and think aloud protocols. And then the other thing, looking at their log files to corroborate. And then the other thing we were doing was terminology evaluation. At the time, people were building controlled terminologies and touting them as the great solution to capturing health information. And then, and their evaluations would mostly be, do you have this term in your terminology? And if the answer was yes, you get a check. And if the answer was no, then you get an X. And then they would just add the term and say, it's in there now. And that was terminology evaluation. But what we looked at was, it doesn't matter if the term's in the terminology if the user can't find it. And so we actually looked at people who were trying to code patient data to see if they were finding the right terms, the terms that they intended. So then they wouldn't just type something in, they would think aloud and say, oh, I want to say this. And then we'd see what they typed, and then we'd see what came up on the list, and then we'd see what they picked. And if they picked what they said they were going to enter, then we got to check. But if they picked something else, the question would be, well, is it not in the terminology? Did we not have the right name for it? Was the screen not organized well enough for them to find it? Was it off the screen? What was the reason for the failure? And we did this with a remote video capture. And so that was really interesting. And we did it with a $2,000 portable usability lab, when we were seeing colleagues doing this with $1 million usability labs to try to understand this problem. So we had a lot of fun inside and outside of the lab. So with that, Andre, please take it away.
Okay. Well, today I'm going to talk about human factors in relation to area I'm working in, as you'll see, a game after a long hiatus, artificial intelligence. And the one thing and I've worked in both of the fields, as you'll see, in different ways and parts of my life. But my observation has been that human factors and AI have had a long intertwined history. And my argument has always been that success or failure of AI applications in healthcare is really closely related to usability and fit of systems, new systems we put in with medical and healthcare workflow. The other thing I want to talk about today is to say that there are methods available for increasing success of AI adoption in healthcare, and Jim has mentioned some of them already. And these are based on considering how to best integrate AI technology with humans, which in a sense is no different than issues we had with many other systems, electronic health records, decision support. So I look at this as an expansion. But I always like to begin with, well, what is human factors as a field? My favorite definition is it's a scientific discipline concerned with understanding the interaction amongst humans and other elements of the system to optimize human well-being. And the term system could be replaced or plugged in with a medical device. A system could be a person, a team, an organization, and it could also be an AI system. So human factors is very broad, looking at the interactions of humans with systems. And they've actually predated computing, in fact, coming out of aviation. Now, drilling down as a subfield of human factors, human-computer interaction, and the acronym we always use is HCI as a subfield of human factors. And the definition I write for this was from the Association of Computing Machinery, that says HCI, or human-computer interaction, is a discipline concerned with the design, evaluation, and implementation of interactive computing systems for human use and with the study of major phenomena surrounding them. So we again see it's quite broad, and today we'll look at some aspects of human factors of AI that cover both from the technical to the more cognitive and social. So there's some considerations when designing for HCI in healthcare, not just for AI, but for any area in healthcare. Well, why is it difficult? And before I got into healthcare, in another life, I worked in some other industries, the transportation industry for a while, and I did a stint actually with nuclear power, with Ontario Hydro, and they were complex areas. But from my experience, there's no more complex area than designing for HCI than healthcare. And we can ask why. Well, the complexity of healthcare. There's a lot of uncertainty and ambiguity about information, about decisions. The problems are often what we term in cognitive psychology as ill-structured. There are many local needs and variations. People want to view and see different types of information. Yet, on the other hand, there's a tension with making standardized interfaces, which we also need. Think about the types of users of systems. In healthcare professionals alone, everything from pharmacists, doctors, nurses, and multiple levels of expertise. And now, as Jim mentioned, we've brought in, since the last 20 years, the patient as the user of systems, like patient portals. Differing workflows, the workflows may differ across institutions or countries. And what always seems to come up is the issue of complexity of integrating anything new with an existing complex digital ecosystem. So I would say this probably makes healthcare the most challenging domain for integrating any advanced technology, let alone AI. And that's why my interest has stayed in healthcare, because it's a challenging area. So AI, well, AI is something I just mentioned. I initially started working in the field of AI and then moved to healthcare. So this was a really long time ago. This was the late 80s, as I mentioned. But AI is really many technologies and many research areas in healthcare, from universities across the world with many different angles on it, each having its own history, trajectory, and I'll talk about expectations. And I would have to say many have advanced considerably in the work over the past 40 years, and we have a resurgence of that coming up today, which we'll also talk about. Now, many different systems. Artificial neural nets were around for a while. As I mentioned, I once worked in Toronto before going to McGill, in a lab there where they did the foundational work in neural networks. Deep learning systems came later, but that was the work of Jeffrey Hinton. So this goes back a long time. Machine learning and data mining had an existence long before the terms have become popular again. Natural language processing, speech recognition, you name it. Predictive analytics, another area. And if we look at the definition of AI, things like predictive monitoring of ICU patients, and I'd argue even intelligent bedside monitoring and systems that can analyze waveforms in real time that humans can't would be a form of AI, beam around. Automated image processing, and of course, big data analytics, and we wouldn't even be able to do bioinformatics or genomics without AI. So a lot of positive moves in this area with, I'm very interested in real working applications of any technology, and since the last 40 years, applications of AI are there in radiology, automated pre-analysis of images before the radiologist looks at them, perhaps marking areas of interest. Dermatology, I have an example from a project I worked on today, everything from alerting, triaging, and decision support. Pathology, again, image processing, cardiology, predictive analytics, alerting. We can look at psychiatry and psychology, automated consultations and alerting of patients that may be depressed using ecological momentary interventions on a cell phone. Robotic surgery, one of my favorite areas I'm looking at now, because we don't have as much of it in Canada as you have in the US. Systems like the Da Vinci robotic system have really revolutionized a lot of areas in surgery, particularly in the US, as I know. Pharmacy, automating tasks like dispensing. We can get into useful applications and things like documentation, reducing clinical burden for doing reporting, education, and last but not least, informational applications like chatbots and generative AI. So in terms of classes of AI in healthcare, we can distinguish between a number. Discriminative AI would be examples of being able to discriminate or classify. This has been quite successful in a number of applications. For example, the one I'll mention today in identifying cancerous moles from an image, classifying pathology images, etc. Another category is predictive AI, predicting flows through hospital, or some examples, predicting a cardiac event or clinical outcomes. And last but not least, as we know, in the last couple of years, generative AI has become really important, and potential applications for doing things like generating reports, generating treatment plans, etc., and interfacing with chatbots, both professional and patient-facing. So from my point of view, I've looked at what are the characteristics of successful applications to date. And we can say for sure AI has been shown to excel at well-defined tasks, particularly artificial neural net applications. However, less so with ill-defined clinical tasks that involve complex reasoning or planning. This is still areas that are not to be cracked. But it's a high accuracy in, for example, from an image detecting if a mole may be malignant or not. Another observation I'll keep coming back to is AI has been most successful when it's supporting and not intending to replace humans in the loop. Unless it's some application where a human wouldn't be able to process all the information, when it comes to decision-making, treatment planning, the support role, which is why the term decision support came up over the years. AI has a lot of potential to support poorly resourced areas. For example, AI chatbots and telehealth in areas where they don't have expertise or humans. But AI models have to be adaptable and updatable. But having said that, one of my favorite business reports is the Gartner reports. And they do this for pretty well all the major technologies. They do it every year. This was from 2023. And it's called the hype cycle. Some of you may have seen this from Gartner.com. And this was the hype cycle for artificial intelligence from Gartner. And it really is a true reflection of what happens when not just AI, but any technology comes along. Well, there's a lot of expectations that build up. On the left-hand side of this, we see when new AI technology. And as I mentioned, AI is actually many different technologies. Often that's lost when we hear the discussions in media, which are often very shallow and not informed. But when a new technology comes into play, we have an innovation trigger, and often there's a rise in expectations about what that technology can do. On the upswing there's a number list of causal AI, data-centric AI, operational AI systems, so a lot of expectations. Eventually, a particular AI technology reaches what they call the peak of inflated expectations. And Gartner in 2023 put generative AI like ChatGPT as kind of getting to that peak now. As you can see, as you move along, there's a drop called the trough of disillusionment. And I've seen this happen with so many AI technologies. There's a reality, and reality sets in. It can't do everything possible. And, it kind of expectations drop. But if the technology is solid and has real value, it comes back up on the right-hand side of this graph on the slope of enlightenment. And there, for example, they located computer vision, which had a lot of expectations and eventually has now become incorporated into commercial productivity, which then hits plateau productivity. But not to be negative, but most of the, over the years, I've been observing, if not working in AI, the cycle is really valid. We can kind of look at where we are with regard to some new innovation. And the other part about this, AIs have a very long history in medicine. Going back to the 70s with rule-based expert systems. I got into AI not in healthcare, but in the 1980s, I worked at the University of Toronto and also an AI group in transportation industry at the time. There were good jobs in Canadian Pacific Railroad. We were automating, and also Ontario Hydro. But one of the things that we found, and the lab I worked in had two groups. There was a knowledge-based group, and incoming person, Jeffrey Hinton from England, was doing neural nets. Now, at the time, we didn't know it, but the work that was on the neural net side took off post-2000. The deep learning was all based on work that Hinton had done, starting in that lab. But what happened in the late 80s in that lab was that there was a lot of overinflated expectation about AI in the world. Every medical school had a prototype expert system or pilot, but in the end, they didn't become incorporated widely into use. So by 1990, if you were applying for grants, you had to change the name to not include AI. My person I work with moved the whole research program into something called object-oriented databases or intelligent databases. Other people stayed working in it, like the neural net people. And I jumped ship because at that point it looked like it was what we called an AI winter. Some of you have heard of that, and apparently there's been a few. But that one really affected my career. And I picked up an article that was done by Miller and Mazuri. It was a 2-page editorial. They were developers of the famous system called Internist. And the article's title speaks for itself. It was called The Demise of the Greek Oracle Model for Medical Diagnostic Systems. And the idea was that physicians didn't want systems that were going to replace them as a Greek oracle they would consult, but wanted something that would be a catalyst that would help them solve problems in their work and their workflow, although they didn't use the term workflow at the time. So for me, it hit me that this really was human factors issue. And the implication was in order to support cognitive processes of clinicians, you need to understand them. And that's when I left working in AI formally and went to McGill as in 1992, as Jim said, to study medical cognition. So I then became interested in human factors. But recently, I've been looking back over the years, and I've done a couple publications on this, if anyone's interested, and looking at human factors issues with AI in healthcare. from pre-2000 to today, and are they still there, and have they changed, and how have they changed? And my argument is, having been working in the field then and coming back to it now, is that essentially some of the human factors issues are still there. The technology has increased and is much better, and there's more practical applications. But some of the main issues that we had then exist today, is the thesis of this. We get issues of trust, accuracy, and legal liability. Now, the question comes up in not just healthcare, but even self-driving cars. What happens if AI makes a mistake? In the human factors work, this is a whole area called failure mode analysis. And this was an issue back then with AI in healthcare, and still is today. Legal liability is part of it. So I was at an AI conference in medicine, it was about 3 years ago, and a lot of hospital managers were there, and there was concern at the time that there weren't a lot of FDA-approved deep learning applications. And I've heard there's more now, but it's not as many as you might think. And a lot of hospitals will say, hey, I don't want the technology if I have legal liability, and FDA approval offload some of that. And if they don't have it, there could be a problem. The other issue is, if the machine makes an error, you get into the argument, is the error worse or better than what a human would make, because the errors are going to be different. Knowledge acquisition, back in the 70s, 80s, and 90s with rule-based systems, the issue was, how do you acquire the knowledge? So there were knowledge acquisition systems developed to obtain rules, essentially. Fast forward to today, and we still have issues, but now we're dealing with large data sets and machine learning, and we're getting issues around where is the data coming from, the training set, are there biases potentially in the data? So knowledge acquisition as a kind of concept is still still a hot topic, or a topic that hasn't been solved. Understandability and explanation capability. Prior AI would, for example, allow a user to ask, how did they do something, and it would display rule sets. Currently, the going technology engine, the deep learning neural net systems, do have a problem, because it's hard for someone to ask it to explain how it came up with a decision, because, as some of you know, it's really an activation of a pattern of thousands or millions of nodes to come up with if something is malignant or not. So this is a whole area of research now called explainable AI. So again, it didn't go away, it just morphed into another research area. Need for effective HCI modes. How do you embed or make the application interact? Is it going to be ubiquitous or embed in workflow? If so, then we need to understand workflow. Another issue that existed then that exists today is challenges of integrating with existing software systems and work processes. Another one I flagged is issue around generalization. I noticed over the years, often the systems have worked better in localized locations, particularly where they were developed, and once you port them over to another hospital or another country, you may not get the same results. And some applications needing common sense reasoning, planning ability, or world knowledge. And the term has come up recently, general AI, and was still not understood what would be required for AI to be general. Safety evaluation, just as with any system, safety is a big issue with AI, especially with concerns of trust or liability. And one of the things I've noticed is that there's been an actual lack of studies of naturalistic evaluation of AI. Still to this day, a lot of the evaluations have been around whether the outcome is accurate or not how does it perform in a real setting like a clinic or a rounding, for example. I mentioned before understanding failure modes, interoperability, and finally integration into real healthcare practices. If we don't test through naturalistic methods, we won't know how it's going to work. So again, not to be negative, on the positive side, I've looked at solutions for this coming from work that I've done with other types of systems that Jim had mentioned in the area of usability evaluation. And the definition of usability here, which came from the 1990s from the human factors literature, could in a sense form a framework also for evaluating AI, because it defines usability in terms of a number of dimensions. If we want to measure usability or ease of use of the system, the dimensions include learnability. How easy or hard is it to learn how to use a system? And we can apply that and develop studies for looking at electronic record systems or AI systems, develop learning curves if that's the focus of what we're looking at. Effectiveness. Does the system do what it's supposed to do? If it's supposed to provide alerts, does it do it effectively? Efficiency. Does the system do what you want, but does it take 10 mouse clicks when it really should only do 5? Satisfaction is the user's perception of it. And last but not least is safety. And all of the above dimensions are essential for AI success. And on the graphic there, I have user experience. UX is another term that's come up very closely related to usability, although it's often used in the broader context of what the user feels about the product or system as well. But I've often used those interchangeably, as UX labs now often are carryovers from what we call usability labs. So this is a world I've lived in and worked in since 1992, when I left AI and worked in human factors. And since then, as Jim mentioned, worked on a lot of different methods for getting testing out that is cost-effective and can be applied anywhere to improve healthcare systems. And we've heard probably of usability testing. I've defined it as simply as observing representative users doing representative tasks and recording them. And as Jim mentioned, we can use a method called Think Aloud, where we can ask the person to think aloud, to verbalize their thoughts, and record the screens. And there's lots of now free recording software, and I do workshops on this, how this can be done basically anywhere. I'm in my office recording myself there using a personal health record, thinking aloud, although they can't hear me speaking there. The whole interaction is being recorded on the Mac. You can record it on QuickTime directly on the hard drive and play it back as a movie file and analyze it. And as Jim said back in the 90s, we didn't have as simple recording as that. You have to have a cart with a PC to video converter and all that. So all that's been removed to something very simple. And the only reason I have a second camera in that picture is for external view, in case you want to see what the person is doing on the desktop. So my argument has been that that can be done effectively, collecting video data that can be played back and analyzed anywhere. It's not rocket science, and it doesn't require $1 million lab. And as Ben mentioned, it can be taken into settings like operating rooms, clinics, and the argument there would be that if you collect data in a real or realistic setting, it's actually more ecologically valid. Work since then, post-2000, with colleague Elizabeth Rickey and others, we extended the concept of usability testing to what we call clinical simulations, defined as observing representative users doing representative tasks in real or representative environments. So this is the area where we can start applying methods to see how well does a system fit healthcare workflow and processes. And the bottom right there is a screenshot of a project we did in Japan. That's the analysis screen, where we merged the external video view of doctors administering IV medications with the screen view, the bigger screen, and we're able to analyze, annotating where there were particular problems, and going back to the developers for optimization. And since then, I haven't counted, but I've certainly done well over 100 projects with hospitals and companies as well around the world, applying some of these methods. So the next obvious thing to do is apply some of them to AI. On the slide here on fidelity of testing, from the lab to the field and back. Sometimes you want to have an artificial laboratory test where you may force a lever through a system to trigger alerts or trigger AI, and then optimize the system. Simulations are in the middle. That was actually a room on the top of a hospital in Denmark where we taught them into doing clinical simulations when they were going to buy a regional electronic health record system. They applied the methods to compare the systems. And finally, on the right-hand side, naturalistic testing, which will require different methods. For example, in some operations, people have used head-mounted cameras, and you wouldn't be asking people to think about it. You'd probably be doing cube recall afterwards into them. At any rate, you may start at one end of this continuum and move to the right, and then the question comes up, you go back. And in some studies, I don't have a reference, I've done some at Mount Sinai in New York, where we packaged that so that before a system was released, it actually underwent laboratory clinical simulations and as much as possible naturalistic testing. So this led to kind of a multi-layer model for considering design and evaluation of AI, but also applied for other systems, a 3-layer model. When analyzing a system, I usually like to start at the level of least complexity because it gets more complex as we go up. So if you want to know if a system is working or not, layer 1 is looking at the user interacting with the system in isolation. This is where you can apply the basic usability testing I mentioned, which will get you surface usability problems, like if they can't see what to click on. You can optimize the system at that level, and then you want to test it in a level 2, which is a clinical simulation. On the right-hand side, I have methods there, and you want to do that to assess impact of system on workflow. So either carrying it out in a simulated or real environment. And then thirdly, if you want to optimize the system, you need to look at the organizational level. What's the organizational impact? Because sometimes you can optimize something at the individual level and the clinical level, and the system still may not be adopted. And often you get into reasons that are turf wars or political, sociological aspects I don't usually deal with. But usually, in working with systems and improving adoption, I like to start with the bottom of the most constrained and then moving upwards, optimizing level by level. So example, the last few years I've done a few examples of AI applications. This one is a dermatology point of care project. It was funded by something called the Digital Supercluster in my province in Canada. And our purpose was looking at integration and evaluation from a human factors point of view. Because I will say, the technology that we used was there. We weren't developing the technology. There was a company, MetaOptima, that had developed a very accurate system for identifying, I'll talk about how it does, identifying accurate identification of melanomas, greater than 90% accuracy. And some markets there, but they want to bring it in to our province in Canada. So the objective of what I worked on was to effectively integrate the AI-based imaging system into a regional healthcare system. So, as I said, the technology is there, and there's papers in Lancet and other places that have, as I mentioned, when AI is being evaluated, the focus has been on outcome. Is it correct or not compared to human or some gold standard? A lot less about evaluating how it could fit into a healthcare system. So the bigger problem from our perspective was how this technology can be integrated into the practices of primary care physicians across the entire health authority. And it actually was in Vancouver, picked up later on, I found out, based on our work. So background in Canada, there are often very long wait lists for specialists, and it's particularly sad case for cancer. Patients may have to wait months to see a specialist, dermatologist, to have a mold check. And if you know about cancer, everyday waiting can lead to progression. We even did a budget model where we tried to prove that if this was carve even a few cases in stage 1, it would be so cost effective. The procedure to correct it would be and in the order of $1,000 versus waiting for an operation if something progressed to stage 4. And every cancer has a cancer doubling time. So in Canada, I'll talk about this. We had a 192-day wait time average from a general practitioner to a dermatologist. So really, there's a need for a technical solution. This company has developed a solution that with the photograph of the mole would be taken in the general practitioner or family doctor's primary care office. They were trained on using it. They were using a dermatoscope, which allows for a higher quality picture. I know some people are doing AI projects where they're having patients at home taking pictures of areas on their body, but we looked at this and said, okay, let's target the GP's office. What would happen is there was a mere analysis by AI imaging software in the cloud, actually, with high accuracy, where there was a well-labeled image bank. So images returned to the GP's office to be compared were ranked and labeled as malignant or not with probabilities on the imaging. So it wasn't coming back and saying, well, this person has cancer. It was coming back with these are closely related images with high probability of cancer. So then the GP can decide to send the report to the specialist, simply hitting a button, and the images and the report go to the dermatologist electronically. That was the workflow. So as I mentioned, our objective was to evaluate the solution and its integration to get the AI into production. And as I said, a wide range of human factors came into play, like how would some of them included how would billing work, was other logistical issues. We initially, another method we use that I'm using for a lot of projects, not just AI, is called patient journey mapping. So we did an initial analysis in this project of where to target the AI from, you'll see in the diagram in a moment, from the point of the visit on to cancer care if you have cancer. We conducted, because COVID was on, Zoom sessions with individuals using the application, specialists, GP, and patients who had been in the room when the doctor was using it, so their comments on that, but looking at the interaction with the devices of the physician. The sessions were video recorded, much as I mentioned about the ACI low-cost methods, and data included audio and video files. So here's the journey map of integration with workflow, and I've labeled it before implementation of this project, and training the doctors on using the device, and after implementation. So as I mentioned before, in Canada, in our province, you go to a primary care exam, they may refer you to a specialist and wait. That could be up to months long. Then we might get a biopsy, wait for results, confirm cancer, wait for treatment, etc. So there's a lot of areas when we're looking at targeting an AI application like this, where we could put this in play, and where would we get the bang for the buck. So after implementation, and you'll see I'll talk about this in a minute, the primary care physician can use the application. In the yellow there's the AI engine assessment online, and in some cases it went directly to the dermatologist to a biopsy. So it shortened what might have been 6 months, in some cases, to a week. So I have it on here. The solution was associated with potential advantage of reducing unnecessary patient transfer times and costs. Before the implementation, the wait time from GP to specialist was 192 days. After implementing, 84% of the referrals from the GP, dermal practitioner, specialist, dermatologist, were now 5 days or less. In fact, when we analyzed the data on the graph, some of them appeared as 0 days. And at first I thought, how could it be 0? And then we looked at it, and what that meant that it occurred in the same day that the that the report was triggered and went to the dermatologist. The dermatologist picked it up, saw the information, and then ordered the biopsy or not within the same day. So it completely transformed things. Now, we're still picking apart how much of this was due to the teledermatology component and how much due to the AI component, although it's very difficult to piece apart. But together, they had a transformational impact. Qualitative findings, it was considered by physicians to be useful and usable. They wanted it integrated with a range of electronic medical record systems to support point-of-care use. As I mentioned, way back from many years ago, the integration of AI with other systems in the digital ecosystem was a problem. So we're still stuck with that today. The initial company with the electronic record system that they were going to integrate with didn't continue, and it was more standalone. It did result in a significant decrease in time getting to not just to the dermatologist, but for those that needed the care for diagnosis and treatment. The patients actually liked the doctor using it. They saw this improvement of care. They said it out of confidence and eliminated a lot of unnecessary stress waiting a long time for an appointment. So the intent here was not to replace human diagnosis, but to flag potential cancers, speed up timely treatment, which could otherwise be months long. So it is a good example of a life-saving application, particularly given our waiting times where it comes from. However, more work is needed on integrating into the whole healthcare system, although it was picked up by a large health organization on the mainland in Vancouver. But I would say that the organizational issues, given the technology was there, are the biggest challenges. And organizational issues are part of human factors, and human factors issues. How do we adopt it? So that's and with some projects that are kind of working in progress right now on this idea of integrating AI solutions. We developed a number of simulation labs at the School of Health Information Science at UVic. On the left-hand side, I'm actually playing the patient in the bed in a simulated hospital room where we're looking at different ways of integrating technologies, not just AI, but electronic health records and decision support. On the right-hand side, the one on the right-hand side is something we call a smart home that was taken during COVID. We have masks on, which is a simulated home environment that's wired up with different types of sensors and technologies, where we are working on developing and testing assistive living devices. So it's also used as a demo place. We work a lot with the local Ministry of Health in showing them what's possible. And we also have some other projects. I won't get into something called Hospital at Home with our local health authority, but this one's a separate project. But they may merge at some point. We're looking at what technologies can help someone stay at home longer. This is the actual room down the hall. We've transformed the storage room into a pretty nice apartment. The water actually doesn't work in that. It's all wired with sensors, motion detectors, fall detectors, smart television, smart fridge. And we're using it both for research consulting and for in our courses on things like systems analysis and design and healthcare. And this was, we actually went through setting it up so that the room would be wired up with the latest technologies, and we continually upgrade it when new technologies come in. This is the idea of helping assisted living, helping elderly, disabled live in their home environment, which brings in AI. We're looking at use cases in the home, things like speech recognition. We didn't have that put in, now we're putting it in. Natural language processing for commands. We could integrate it with ChatGPT. Haven't done that yet, working on it. Context-sensitive help around the home. We can get into automated analysis of interaction with devices, cooking, plumbing, sleep patterns. And this can range. It doesn't necessarily have to be the most complex data science. You can do that to analyze sleep patterns. But in a lot of cases, a simple alerts or alarm that would indicate for a caregiver living somewhere else, like in another city, someone's elderly parent lives in Vancouver and they live in Toronto, on their cell phone that there hasn't been any activity in the plumbing or cooking. And there were a lot of use cases we came across where that led to someone being checked in on and the hospitalization if they'd fallen and not got up. Automated alerting and reminding about both healthy and unhealthy patterns of daily life, and automated alerting about dangerous situations, or on the smart TV and the large font for the elderly, coming up with reminders and alerts about taking medications. So we will be using patient journey mapping to find out where and when to best integrate and trigger different AI support and analysis. I will say we have some recent additions to the labs. An unusual thing happened. The government gave me some money to buy things, extra toys. So we bought a whole bunch of working technologies. These are some robots that have been used in production, but we just unpacked them essentially. There's a robot on the left-hand side that's pretty autonomous, a short one called Mayo. Pepper in the middle, this is unpacking Pepper, has been used in hospital settings for things like wayfinding, but we're also looking at could it be used for monitoring at the bedside as well, especially if it's short of staff. So we're looking at doing reviews at the moment on the cases for robotics in healthcare. This one is an area that we just published a few articles on, but gets into the AI and robotic area. It's a mode design for AI and human-robot interaction. We've done initial scoping reviews about what makes interaction emotive or real to users with AI or robotics, and came up with development of categories of aspects of design that led to this, like personalization, engagement with the user, reward, imagery, content, usability, and the case of robotics will include what level of tactile response. In the photograph there, we also brought something called Pero, we called it Miso. It's a therapeutic robot seal that's actually being used in elder care homes. And if you ever come to see it, it's amazing. Once you turn it on, it kind of affixes on you, personalized to your voice, and unbelievable. When we turn it off, everybody in the office where we have it, it's been actually a real team builder. Everyone wants to see how Pero's doing. So at any rate, we developed this, I won't get into today, a set of heuristics under these categories I showed, and first run at this 49 of them, and we're using the heuristics for interaction design and evaluation in healthcare of new technologies, including AI and robotics. And now integrating AI solutions and reasoning about human-computer interaction. Also interested in applying methods like focus groups, interviews, looking at where to insert AI and what the possible range of use cases are. These are the sum on this slide: consulting mode, critiquing. Is the AI augmenting human perception or extending physical access? Is it running in the background, or is it best to run in the background in the ubiquitous mode unless there's a problem? Alerting, reminding, which, as I put there, is a direct extension of the rule-based AI. It didn't go away, it just morphed into something else. Machine learning, generating text images, or advising. So we're exploring this from a use case point of view. And as I mentioned, the concept of patient journey, we're applying this in cancer care and other areas with all kinds of systems. This is a patient journey map that goes from, on the left-hand side, pre-diagnosis to diagnosis, to treatment, to remission. And we've applied collecting data for patient journeys for different illnesses and conditions. And we read it from left to right. So you can go through the stages a patient goes through, and then identify where technology has been inserted or where there's opportunities to insert the technology. So in a sense, it's kind of a patient workflow, if you will. And the lessons learned to date from our work, I'll just end shortly. AI has to be inserted for a task that AI is proven to be good at doing, obviously. Must be accurate, but that's not enough. must be useful. It must solve better patient care, saving time, or better organizational outcomes, like I presented in the dermatology project. We have to consider how it affects work practices, workflow, reasoning processes, and ultimate decision-making processes with human and machine considered together. Patient journey is something we found useful for doing this, and safety is obviously a paramount importance. For testing AI, we need to test the solution and compare, but also compare the other alternatives to see if it's needed in the first place or how it may be better. And failing the test for things like extreme conditions, usefulness, usability will likely lead to failure for adoption. And this was a lesson over and over again. Over the decades I mentioned, AI research has been going on, and how I often feel gets forgotten in the excitement of the latest technologies. And the need for testing systems in new environments, in situ, laboratory, but also in situ naturalistic evaluation. And implementation and deployment failures with AI can come from deploying underperforming systems that don't adapt to the environment, security and privacy being left out, and failure to explain to users how the AI works, its benefits, its limitations, even if you can explain technically an activation cloud on the neural net, generally how it works and where it might have advantages or potential failures. And last but not least, this fits with a paper we did before we got into looking at testing AI, because it applies this as well. If we want to ensure, we've also done this graphic as a safety net, that if a system is safe to be released, we really should go through a number of test phases, starting at the left with evidence-based heuristic evaluation, correcting the defects, going to usability testing. Simple testing, like I showed, will suffice at that point. Correcting defects, clinical simulations, more closer to real life, correcting those defects, and last but not least, going through naturalistic testing, at least with a subset of a hospital or user set, and then before full release. And then after full release, of course, there's still be issues that need to be addressed. But if we go through these phases, and we've shown this in a number of projects, real-world projects and publications, the chances are there's a lot less that will need to be done to rectify problems from the user perspective at the end of the day. So key conclusions: human factors are critical to AI implementation. AI can enhance and improve patient outcomes. However, attention has to be given better attention on how and where AI is implemented, and to identify and test integration points in the digital health ecosystem. But on the good side, methods and tools exist that support AI testing and integration prior to implementation, and our argument that if it is done in a rational way will lead to better improved adoption. And hopefully we won't get into another AI winter, which I don't ever want again. Thank you. That's my presentation. And if you at all interested in this, that's my email address, andrek@uvic.ca. Thank you.
Jim has a question.
Yes, thank you, Andre. That's what a great tour de force. Yeah, I want to go back to the question of safety. You know, we hear stories about, you know, how chatbot tries to convince a New York Times reporter to leave his wife because he's obviously in love with the chatbot, or a guy who has an AI girlfriend, and the AI girlfriend confirms that, you know, suggests that she will love him more if he goes to try and kill Queen Elizabeth with a crossbow, and he makes it as far as the grounds of Buckingham Palace with a crossbow. And one guy who was convinced by a chatbot that he was a drain on the Earth's resources and he should kill himself, and he did. So, you know, there are real concerns about safety, and I'm wondering what you think about guardrails on, for instance, consultation systems, where the system might recommend something. You know, remember, if your training is including things like, you know, open crawl, then there's stuff out there recommending, what was it, bleach for COVID? So, how do we put guardrails on, or do you think that's going to work?
Well, that's that point about the fine line between recommending and then telling someone what to do, and that's where that the very subtle point. The dermatology project I worked on, I asked them how did they get around certain regulatory. They weren't getting around them. It just simply said that it wasn't going to tell them what to do. It was like an intelligent visual search that then, like if you did a Google image search of a mole, and then it would compare it to right. So it's that very subtle interaction at the interface with the human that makes all the difference, especially in healthcare. Also, the safety one we mentioned is something that simply, and this I haven't seen as much. I mean, I've watched some television debates with Elon Musk and others about the safe or the not safe. They actually don't usually talk about what technology AI they're talking about. And why would AI be any different from any other one, technology in healthcare? So yeah, you want things like FDA approval or the left form behind, but you have to really work on all the methods for testing before releasing. And a lot of it we won't actually know. I'll give the example of self-driving cars. There were so many arguments that they're going to be safer. That's why we should put them in. No one could ever prove that. The problem with it is we won't really know until all the cars are on the road, self-driving. And even the companies doing it are trying to develop AI simulation data banks of different accidents to see how the car will respond, because they don't know. So it's premature with some of them to say that it's going to be safe, but they shouldn't be released until they have some better metric of safety, like the self-driving cars as an example. So safety is a big one, but also I think that interface, what you hit with someone taking AI-based output as a command, is a problematic human-computer interface where the person had taken it as that there was value in what the system was telling them. So in the healthcare area, same thing. We can provide information to guide, and another area I've worked in is on clinical guidelines, how to integrate them in EHRs in a way that doesn't make the physician feel like they're being told what to do by the system when they feel that the system may not be correct. So I think a lot of that has got to do with human factors. And my answer has always been testing in environments, testing those devices like Alexa in the home, and then putting in guardrails or putting in ways of detecting when it's going to tell. There was a case of, I think, Alexa telling a child to attack the parents, and exactly the same thing going on. So if we just unleash the technology with no testing on what the potential consequences are, we'll get those weird cases.
Okay, thank you. Other questions? People are going to start dropping out, of course, because we've got back-to-back Zoom meetings, but.
Yeah, we are at time, so I don't know if you're able to stay for a few more questions, and people should not feel obligated to stay if they have another meeting. But
Wayne, hey Wayne, looks like Wayne has a question, but I do have to drop off. Andre, thanks very much.
Okay.
Will we see you at AMIA in San Francisco?
Hopefully.
Okay, good, very good. Thank you.
Yeah.
Hi, I'm Wayne Lee. I'm former faculty at UAB. I'm currently at Emory, and I'm involved with operations, informatics operations. And I completely agree with everything you shared. In my experience with implementing or supporting the implementation of AI-based tools in healthcare, those questions of is it accurate, but very importantly, is it useful, is extremely important. And what we're also facing now is also, even if it's accurate and useful, we have to overcome the barrier of what is the financial ROI? What is the return on investment? So for example, right, we've evaluated ambient documentation using the AI tool to listen to a conversation with a patient and write the note for you. In our pilot evaluation, it's been very well received by our physicians. They really like it. But the challenge here is in adoption in a real health system is now, how much does it cost? And does it save us any money? And if it doesn't save us any money, we might not be able to adopt it, even if it's accurate and useful. The other thing I was doing just yesterday, I was trying out a new tool in our EHR that summarizes the patient's chart using ChatGPT as a backend. The idea of it is fantastic. I've been looking for a tool like this for a very long time, but the actual usability implementation was not great. And I'm struggling now in how to use this tool. We need to overcome that barrier of, the human factors barrier. Even if the technology works, you got to overcome the usability of it to even consider training my non-informatics colleagues or encourage them to adopt it. So just want to bring up, complete jive with what you're saying and what you mentioned, but I would just add that financial ROI piece for real world implementation and, dissemination beyond evaluation of a tool.
I think, and this is interesting, I think you're bringing in the voice of the management perspective often isn't brought in. I was at, okay, well, this 2018 was a while back now, but it was an AI conference in California and LA, and I was on a panel and they had the management from hospitals there, and they brought up stuff we hadn't really thought about that. I remember from that one, it was, they mentioned ROI, the legal aspect. At the time, I was surprised that the FDA hadn't approved a lot of neuromed applications at that point. It was like, if I was correct, it was only like about 100. The FDA was having trouble finding people that even knew how to evaluate the technology. So that some of the managers said, well, if we adopt it, then what happens if there's an error and we don't have that stamp of approval? So there was a liability, and the costing was another one, the saving time. So those came up. The other one about the I'm only looking at some now with the summarization of interviews, and that was even before the ChatGPT. I had a student who was a physician and was using Dragon Speak, speech recognition interface on it. So this is up in Canada, but it automatically transcribed. And she said that they were so busy they never had time to check it. And even if it's 97% accurate, she said she saw cases of reports that cancer was not cancer, vice versa. And I haven't worked with that with ChatGPT, but I assume that would be another sort of thing is, okay, how do you get the double check on the accuracy? So again, some of the things that the management come up with, I've been writing a lot to the human factors people, and recently I did one paper that was called "What Should Management Know About Human Factors?" Because we spend millions on systems, a lot of it goes down the drain because of usability. And that got a lot of airplay, and I realized probably the management is somewhat disconnected in the arguments. I think bringing them in brings in some very valid human factors issues that really do need to be brought out there. So I think being open and transparent and bringing in everyone. And then that's a way also you don't get those false expectations. If everyone's kind of open about it and looking for different perspectives. Back then, when there were inflated expectations, it was like something really good was going to come out, and then all the holes were shot into it. So I think being really inclusive about different perspectives in it, and the testing. Yeah.
All right, we're way over time, so thank you very much for the great lecture, and also for everybody for the great questions and for staying till after time. Hope to see you at the next Power Talk. All right, thanks everyone. Bye-bye.
All right.